Hello everybody. Today's journal for presentation is Aspirin as a treatment for acute respiratory distress syndrome, a randomized placebo-controlled clinical trial, STAR RCT. There is no widely accepted pharmacological treatment for ARDS, and platelets play a role in pathophysiology of ARDS. In ARDS, basically lungs act as a site for platelet maturation and platelet activation, thereby platelet aggregation, which further recruits additional platelets and leukocytes to it. This promotes production of aspirin-triggered lipoxin. Basically, this is pathophysiology of ARDS, how the neutrophils are attracted by the platelet aggregation, and this produces aspirin-triggered lipoxins. These aspirin-triggered lipoxins are basically beneficial for the basically this is defense mechanism for the murine models of ARDS have shown that platelet depletion, aspirin administration, and aspirin-triggered lipoxin administration, they improve various outcomes like reduced neutrophil migration, pulmonary edema formation, and even improve survival. Aspirin reduces alveolar inflammation and injury in a human ex vivo lung perfusion model of ARDS. And aspirin 75 mg was age effective as 1200 mg daily in reducing pulmonary neutrophil infiltration and cytokine production in healthy volunteer model. Previously, the animal models have suggested higher doses of aspirin have beneficial effect, but later on the healthy volunteer model could find that aspirin 75 mg is age effective as the higher dose. Basically, this study is based on the previous study, which is LEAP-SAVE. The study LEAP-SAVE, lung injury prevention study with aspirin. This is for prevention of ARDS, not for treatment of ARDS. And this study, published in JAMA 2016, it reported that low-dose aspirin did not reduce incidence of ARDS within 7 days in patients at high risk of developing ARDS. This is for prevention of ARDS. The patients with long injury prediction score more than or equal to 4 were taken, and there is no difference in incidence of ARDS in patients treated with aspirin and the placebo. But this study was limited by the low incidence of ARDS in this study cohort, just 9.5% compared to predicted of 18%, which limited the ability of this study to detect any statistically significant effect. Similarly, the subsequent sub-study of this trial, the major trial, of 367 patients also, of which 24 developed ARDS, and incidence of ARDS was numerically lower in the aspirin-treated group, 10 patients versus 14 patients, though not statistically significant. This study is also limited by the underpowered nature of the study. This is these two major studies. Previous study, LEAP-SAVE trial, published in JAMA 2016, and another published here in Lancet 2018. These two studies form the background of this recent RCT, STAR RCT, published in CHEST. I have quoted here the LEAP-SAVE RCT. Basically, this RCT was conducted over 16 US centers. It is a multi-center trial where the aspirin almost 325 mg loading dose followed by 81 mg per day, or placebo, almost 325 total 195 in each group. And the primary outcome was development of ARDS by study day 7. But among 390 analyzed patients, median hospital length of stay and all that did not differ. Administration of aspirin compared to placebo also did not significantly reduce the incidence of ARDS at day 7. Coming to the study hypothesis of the recent trial, STAR RCT. The hypothesis proposed was to determine if aspirin improved the surrogate clinical outcomes and was safe in adult patients with ARDS. It was a randomized double-blind, patient and investigator blinded, allocation concealed, multi-center placebo-controlled phase 2 trial. It was approved by National Research Ethics Committee and sponsored by Belfast Health and Social Care Trust, coordinated through Northern Ireland Clinical Trials Units. Basically, UK-based study. Inclusion criteria. The report has been prepared in line with the CONJURE guideline, Consolidated Standards of Reporting Trials. being RCT. Patients were recruited from 5 ICUs across Northern Ireland, and invasive mechanical ventilated patients within 72 hours of onset of ARDS. ARDS was defined as per the Berlin definition. They were included in this study. Exclusion criteria: contraindication to aspirin or antiplatelet therapy. Adjusted platelet count cutoff. At first they taken is 50,000, but at first they taken is 1 lakh, or later on that decreased to 50,000. Patients on methotrexate on 15 mg or more per week. Active for recurrent peptic ulcer disease was limited to active disease within previous 5 years. And imminent treatment withdrawal, they were excluded from the study. Randomization: subjects were randomized to receive enteral aspirin 75 mg or placebo. Randomization was stratified by vasopressor use. Patients were randomized in 1:1 ratio using blocks of variable size. Aspirin 75 mg and placebo had an identical appearance, but packaged identically and identified only by a unique pack number. An independent clinical trial pharmacist allocated the next sequential number as per computer generated randomization schedule, and he was the only person with access to randomization schedule. Patients and investigators were blinded to treatment allocation. A member of the ICU nursing staff who was not involved in the trial administered the study group. Treatment for maximum 14 days was selected, taking the median duration of mechanical ventilation 6 with IQR of 2 to 12 days. That's why maximum 14 days treatment was selected. Study drug was continued until first of the following, like 14 days after randomization, discharge from critical care or death, drug-related adverse effect, following request from clinical team or legal representative on development of a condition requiring aspirin as a treatment, or if hemoglobin dropped below 7 gram per ml. Coming to data collection, etiology and severity of ARDS, neural long injury score, SOFA, Apache 2 score, all were collected. Daily data collected at or at close to 10 hours as possible, like ABG, ventilator requirement data, SOFA, clinical and laboratory data. Plasma, urine and bowel samples collected when possible. Clinical care delivered in accordance with the local guidelines. Coming to outcome, the primary outcome was oxygenation index at day 7. Oxygenation index is a physiological index of severity of ARDS, and it measures both impaired oxygenation and amount of mechanical ventilation delivered. That is, oxygenation index is mean airway pressure multiplied by FiO2 divided by PO2. That is mean. And decreasing oxygenation index basically correlate with improving oxygenation. Secondary outcomes were oxygenation index on day 4 and 14, respiratory compliance and PF ratio on day 4, 7 and 14, change in SOFA score from baseline to day 4, 7 and 14. These were the three were secondary outcomes: change in SOFA score, respiratory compliance and oxygenation index on day 4 and 14. Patients were assessed for any adverse effects up to 28 days after completion of the drug therapy. Sample size: previous clinical trials like of oxygenation index at day 7 in patients with ARDS is 62. Mean ST of standard deviation of 51. A sample size of 56 participants at 80% power, and alpha error of 0.05 to detect difference of 39 centimeter water per kilopascal in oxygenation index. Assuming a dropout rate of 3% from previous ARDS trial, it was planned to recruit a total of 60 patients. Statistical analysis: unadjusted analysis used independent t-test, and adjusted analysis were taken using analysis of and cohort to adjust for baseline values. The ventilator free days, score, duration of mechanical ventilation, length of stay, outcomes were summarized using median and IQR and tested using Wilcoxon Ransom test. The categorical variables were tested using Fisher report. A linear model was used to compare change over time in a range of clinical laboratory assessment, including full blood picture, renal function, and coagulation screen. All available data points were considered in the model. Treatment was the fixed effect and patient was the random effect in the mixed model. This model provides an estimate of fixed effect while adjusting for the non-independence due to repeated measurements on each subject. Coming to results. Patients were recruited from 10th Feb 2015 to 25th November 2018. Recruitment ended in 2018. During this 45-month period, a total of 593 potential participants were screened with 8.3% successfully recruited. The Data Monitoring Committee reviewed the unblinded data throughout the study, and in November 2018, Data Monitoring Committee recommended closure of the study after 49 patients of the planned 60% had been recruited due to slow recruitment. They recommended closure of the study. 24 patients allocated to aspirin group and 25 to the placebo group. So 49 patients were recruited, 24 in the aspirin and 25 in the placebo. All patients received their allocated medications and no patient withdrew or was lost to follow. This is a conjure diagram how the 593 patient assessed, 49 randomized, 24 to aspirin and 25 to placebo. Then no loss to follow. Analysis of 24 and 25. Coming to baseline characteristics. The aspirin and the placebo group almost like aspirin group has more male patients physically and higher baseline Apache 2 score compared to placebo. Male patients are more higher baseline Apache, and they had lower vasopressor requirement. Vasopressor required 13, here 16. And SOPA score almost comparable, 9 and 10, both the groups. The pneumonia was the leading cause of ARDS, almost 58 and 52% in each group. But placebo group has more of sepsis-induced ARDS, as they have written. Sepsis leading to ARDS is more in the placebo group compared to the aspirin group. Coming to the outcome measures, the oxygenation index measured at day 7, which is the primary outcome. There is no difference in the primary outcome, basically unadjusted and adjusted. Both they have seen. There is day 7, the observed value and the imputed values of the those who data were not could not be collected, but there is no difference in the placebo versus aspirin group in the primary outcome, which is the day 7 oxygenation index. Then oxygenation index here at day 4 and 14, which is one of the secondary outcome. This also did not differ between the two groups. The P groups did not differ between the two groups. The oxygenation index at day 4 and 14. Other secondary outcomes like compliance also did not differ between the two groups. The P group is not statistically significant. Then PF ratios and change in SOPA score from baseline. These parameters also did not differ in the two groups. Neither of the primary outcome or secondary outcomes differ between the aspirin or the placebo group. Then clinical outcome for each group, aspirin and placebo, the median ventilator free days up to day 28. This also did not differ. 16 days in aspirin group and 15 in the placebo group, ventilator free days. Duration of mechanical ventilation also did not differ between two groups. All patients, even the patients who survivors also, the duration of mechanical ventilation did not differ. The length of stay also did not differ. Hospital length of stay and ICU length of stay did not differ between the two groups. Similarly, mortality, the 28-day and 90-day mortality also did not differ between the two groups. The P value is not statistically significant. The primary outcome oxygenation index did not differ. The other secondary outcomes like oxygenation index at day 4 and 14, respiratory system compliance, the change in SOPA score, they did not differ. Other outcomes like ventilator free days, duration of mechanical ventilation, length of stay, and mortality also did not differ between the two groups. This is the biomarkers like plasma thromboxane B2 concentration. Here in this figure A, it is the black line is showing the trend of thromboxane B2 in the aspirin group. Here the gray one is the trend of thromboxane B2 in the placebo group. The black one is the aspirin group. Obviously, the thromboxane B2 in aspirin treated groups, the trend is decreasing from the placebo, but it is not statistically significant. The p-value here it is some 0.07. Similarly, the CRP values also they did not differ between the two groups. In this trial, investigating aspirin as a treatment of ARDS, no significant difference in primary outcome of oxygenation index at day 7. Aspirin did not have a significant impact on any of these secondary outcomes, and administration was well tolerated with a similar number of adverse effects in both the groups. The higher doses of aspirin are more likely to result in adverse effects. So, in this STAR-RST, they considered 75 mg dose. In a study comparing IV, oral, chewable, and entry-coated aspirin administration in 66 critically ill patients, plasma concentration of acetyl salicylic acid were not only highly variable with the oral administration, but also substantially reduced compared to the healthy volunteers. So, the authors have a suggestion to compensate for the changes in pharmacokinetics. An IV form of aspirin might be considered in the future clinical trials. That can be the reason for no effect because in critically ill patients there is obvious change in pharmacokinetics and dynamics of the drug. As with other ARDS study, here the limitation, this trial also recruited a heterogeneous population with wide range of etiologies and did not differentiate between hyperinflammatory and hypoinflammatory soft phenotypes of ARDS. These soft phenotypes of ARDS, which differ in clinical and biomarker characteristics, not only but also in outcomes also. Both hyper and hypoinflammatory, according to that, the drug can have variable effect. A precision medicine approach identifies the subgroup of patients who might be more treatment responsive to aspirin might be useful, and failing to achieve the target sample size impacts on the interpretation of the results and has implications for any further trials. Like here in this trial, almost 500 patients they assessed, but only 8.4% or something could be recruited. Importantly, only 8.3% of the 593 patients who met the criteria for screening were successfully randomized. This potentially limits the generalizability to a wider population of patients and makes the feasibility of a large interventional study of aspirin ARDS questionable unless further studies are less restrictive in the exclusion criteria. Coming to conclusion, aspirin 75 mg daily in patients with ARDS showed no improvement in physiological markers of pulmonary or systemic dysfunction. These data do not support use of low-dose aspirin in the treatment of ARDS. Furthermore, feasibility of a large interventional study of aspirin in ARDS is questionable unless further studies are less restrictive in their exclusion criteria.